So we are now about to hear from our startups. I just want a reminder very, very quickly of the rest of the agenda. And we are going to go into the next presentations. And Nico, will you tell us really quickly about the Audience Choice Award?
Yep. So this is one of our favorite parts of the pitch challenge. It is important that you're following along with the judges and the founders because you all will be voting for this award. The criteria includes impact, differentiation, scalability, technical feasibility, economic feasibility, team, and quality of work. So just take a second and note that for when the poll opens after all the pitches so that you guys can vote.
Now we have our first four finalists that are Series A and Seed. One caveat with regards to the actual judging, please remember the stage of the company. So we're starting with the companies that have raised the most money and going to the ones that have raised the least, ending with our nonprofits. So it's really important because not every company is the same. Also, please remember, we're asking each founder to take 5 minutes to describe their company. It's impossible to describe a life's work in 5 minutes. So if you just please keep that in mind, and then they will have 5 minutes of questions from our esteemed panel of judges. So first up is Teo at Hera Diagnostics. So Teo, we are excited to hear about what you're building.
Hello, can you hear me?
Perfect.
Wonderful, wonderful. So we'll get started. So my name is Teo Tijerina. I'm the CEO of Hera Diagnostics. Next, please. We are a company that is designing diagnostics that are suitable for global use. And the first area we're tackling is cervical cancer, where 342,000 women continue to die each year. What's an outstanding, incredulous fact is that 90% of these deaths occur in middle to low-income countries. Next, please. So why is this happening? First of all, there's a lack of screening. That's a major contributor. But also, it's pretty clear from data that screening methods in low and middle-income countries are poorly executed. Finally, evidence also exists that screening is not perfect in the developed world. A recent article in the New York Times showed this, where a pap smear had a false negative that turned out to be terrible for this wonderful woman who was an advocate for women's health. Next, please. We also see market opportunities. New technologies are shifting diagnostics away from third-party labs. This represents an opportunity for increased revenue for doctors and lower costs for the industry. In talking to a family friend who's a doctor, he tells me, I make very little money on the pap smear test. A big portion of the cost goes to the lab. Next, please. So in examining the cost of the pap smear in both the US and Mexico, it became clear to us that the lab pathology is a very big component of the cost, 38% in Mexico and about 48% in the US. Next, please. So to address these health problems and to also take advantage of the market opportunity, we've created HeraFem, technology developed by 3 Mexican scientists at Monterrey Tech University. It's a point-of-care cancer screening device that's capable of detecting SIN2 or above, that's pre-cancer or above. And in a study we did of over 200 patients, our sensitivity was 91%, and the AI and machine learning components of the device will improve this over time. It's a device with a biosensor disposable sleeve. Next, please. So HeraFem addresses the weaknesses on a global scale for the pap smear. First of all, it's very affordable. Second, it's extremely accurate because you're removing a lot of the human element. The real-time results allows you to reach marginalized women, particularly in rural communities, as well as the portability. And there's no healthcare infrastructure required, laboratories, or no sample and no transportation, et cetera. Next, please. Why, besides the wonderful patient experience and the impact to women, why do we also think doctors will be motivated to adopt HeraFem? Looking at this quick scenario that we started looking at in the US, there's a real opportunity when you remove the cost of pathology to improve the margins that doctors are making and also reduce the cost of the total pap smear or cervical cancer screening to the industry. Next, please. Our business model, we're going to market in Mexico first. We will initially have a customer acquisition cost of around $1,100. This will go down substantially over time. Because it's the razor blade model where we sell one device, where we keep selling disposable sleeves, the lifetime value over 5 years is $21,000 with a very, very good gross margin. Next, please. This is our timeline to go to market in Mexico, where we're starting first. We expect to get to sales in Mexico this July, after getting the Mexico COFEPRIS or FDA in June. Next, please. Our first 10 markets include the United States, Mexico, 6 countries in Latin America, China, and India over 10 years. With very modest market capture, we will get very, very good revenue. This represents more than half of the total pap smears in the world. Next, please. So we are projecting that in 10 years, we'll be over $100 million revenue company, and very, very solid EBITDAs due to the recurring revenue component of the sleeve. Next, please. We're playing at the intersection of 3 very lucrative categories: artificial intelligence, oncology, and women's health, that are trading close to 25 times EBITDA. Next, please. And this is our team. We are a US corporation. We are 50% US founders, 50% Mexican founders, 75% Latinos, and 40% of our founders' shares are owned by women. Next, please. And that is it. Thank you so much. I would like to entertain any questions you might have now.
Thank you so much. I believe that Elizabeth, you have the first question.
Okay, thanks. Thanks so much, Teo. Cervical cancer is such a huge problem, and good diagnostics, reaching as many women as possible, is going to help to solve that. I am curious, as you think about the market opportunity, there's been the introduction of the HPV vaccine, and whether you see this as a static market, or a growing market, or a shrinking market in the face of that?
That's a really good question. We believe that the market will probably be pretty consistent over time. The HPV vaccine, which we're big fans of, will help reduce the incidence of how many women are dying and getting cervical cancer definitively. What we have seen is that the vaccines, the ones we have today, one is they do not take into account sometimes the strains that are causing cancer are not the same in Europe and the United States as they are in Africa or Latin America. 2, we all know that viruses like to mutate. So that's always going to be a catch-up game. And so we see the need for ongoing cervical cancer screening for many, many decades to come. It's hard to predict whether the market will grow or stay the same or decrease slightly, but we don't see it definitely going away anytime soon.
Thank you. And I believe, Courtney, you had the second question.
Yeah, thanks. This is super interesting. Can you just talk about the regulatory landscape in all the countries? Talked about a bunch of countries and getting regulatory approval in Mexico. What is the process or hurdles, to sell across all those different countries?
Yeah, Mexico is, we're starting first, mainly because the technology was born there, and also because we really want to work in parallel as we start looking at the US and Europe. We want to work in parallel with deploying this in developing countries where we know 90% of the women are dying, and we want to have that social impact. The regulatory hurdles in Mexico, for example, it's a lot faster and cheaper to get to market. We are spending probably a couple $100,000 to get to market. And Mexico has a Pacific Alliance with 5 countries in South America, that if you have the COFEPRIS in Mexico, you get fast tracked to several of these countries in Latin America. So we expect by the end of our Series A to be doing about 20 million in sales just from Latin America. We do want to start the FDA work as quickly as possible. The only thing that has held us back has been capital. We do believe that we're barely starting, to be honest, to study the US market and understand how to best put it. And we're looking for partners and really intelligent people to help us in this. We believe the patient experience and the opportunity to drive revenue to practitioners could be very interesting for the US market. And then single payer markets, for sure, governments have a big incentive to reduce costs. In terms of regulatory, the US does not have a precedent with optoelectrical spectroscopy, which is what we use. So we think this is going to be a little bit more of a challenge. In CE mark, there is precedent for this technology. We expect that to be faster. So that's the current landscape. Now, China and India, we plan to really work with probably some joint venture or licensing partners is what we're looking at. Those are very different cultures and countries to what we're accustomed to. So we're talking to a few people that are interested in taking this to market in those countries.
Great, thank you so much, and wonderful questions. Taylor, you'll see there's a lot of love in the chat for you.
Thank you, thanks everyone so much.
So our next presenter is Siggy from BabyLiveAdvice. Siggy, we welcome you to the stage.
Hi, can you guys see me and hear me okay?
Perfectly.
Excellent, thanks. We can go to the next slide. Well, hi everybody, my name is Siggy Marmestein. I'm the CEO and founder of BabyLiveAdvice. BabyLiveAdvice is an integrated telehealth solution that improves maternal child health by supporting women virtually from preconception to 1 year of age. Next slide, please. As you all know, the US is the deadliest place in the industrial world by which to have a child. Reasons for that include many reasons, but the challenges that we are facing here in the US is that most of our births are covered under Medicaid, with less providers and less medical providers to care for women. Social determinants of health, maternity desert, and others, creating a chain reaction by which women are not receiving pre- and postnatal care in a timely manner. Next. We also hear from women that they are confused and have less of education that they need to know about maternity, the delivery process, or parenting. Sadly, in our United States system currently, a parent will find themselves in front of a medical provider only 4 to 6 hours in total in 2 years, from the prenatal to the postnatal time. Next. BabyLiveAdvice is actually a service that is empowered by technology. The technology is our own. It's sitting on our own EHR system that can integrate with many other EHR systems. We provide services that are rendered by doulas, nurse practitioners, lactation consultants, mental health providers, and others who are culturally fitting to the patients that they are serving. We serve parents from in their home and in their language, and we have a 250 language translation. Ultimately, we have proven to show better outcome, reduce of cost, and excellent adherence. Next. As you can see, we provide many of the services that are required to support a parent from preconception to 1 year of age. With our solution, all of our services are in one place, reducing the need for point solution and that confuses usually the parents as well as the providers. Next. We also developed a remote patient monitoring capacity that is being actually monitored by our own providers, only escalating emergencies to the medical team. Next. BabyLiveAdvice is part of the entire maternal journey and the infancy all the way to 12 months of age. As doing so, we are closing care gaps in an integrated loop system that does not silo the parent or the provider. Next. There are many benefits to BabyLiveAdvice. They are on economic, operational, and strategic. Ultimately, we reduce ER utilization and higher level of care. We reduce providers' burnout, and we increase the touch points of the parent with their health system. Next. We had served many parents to date. Our adherence rate are very high, 78% month to month. And all of our providers and our patients are always rating us at 95% of satisfaction. Next. In 3 clinical studies, BabyLiveAdvice is proving to also have a very strong outcome data on clinical outcomes, such as C-section, reduction in surgical intervention, readmission, and we have improved breastfeeding and PHQ-9 scores. Next. BabyLiveAdvice is all about health equity. We care for parents regardless of their geographical location, their language, their race, the ability to pay, or the actual location. Here are some of the pictures of patients we have cared for last year. Next. We have many partners and supporters and have served many parents in the last 4 years of our existence. Last year, we closed our seed round, a $1.3 million seed round, and are on track to make $3 million this year. This year, I'm very proud to say that we have joined Walmart, CareSource, and Johnson & Johnson in caring for parents in Georgia. I highly encourage you guys to visit Georgia Mama Care, which is the website that is empowered by us, to look and see the work that we are doing in the state of Georgia with Black women. Next. Our team is our power. We have excellent expertise, both in medical as well as in health innovation and technology. And our team is the one who are pushing us forward and helping us to make the right decision strategically as well as technologically. Next. Thank you so much, HITLAB, Susan, and all of you for having us here today. I will take any questions if you have them. Thank you so much.
Thank you. I believe, Courtney, you have the first question.
Thanks. This is great. I think one of the things I like the best, and if you can say a little bit more about it, is the fact that the data gathering is sort of monitored by your team real time. Is that right? Because I think we've looked at a lot of remote patient monitoring technology. I think it's really promising for maternal care, but I worry that without a triage layer, the doctors won't know what to do with everything. And so can you just elaborate on that?
Absolutely. First of all, I'm a nurse practitioner. I've been working in the healthcare field for 32 years. So yes, you're right. Physicians and nurse practitioners and others, we don't have any time. We hardly have a time to go pee. So let alone do we have time to actually monitor patients or looking at data or even reading soap notes. So what we do is we actually interact with the health system. We are a part of the patient chart. We collect the data and only escalate emergencies to the physicians when clinical implications are required. That really does help the provider to ultimately know when to treat the patient and really help them to also spend their time on those patients that really do need the most care.
Yeah. And walk me through how the money flows.
Everybody asks about the money. Well, 90% of the time. So the first thing everybody should know is that BabyLiveAdvice doesn't charge the mom a dime. So for all of our parents, and we have quite a few of them, this is a free service. Who pays for it? The hospital, if the hospital is paying for it. The healthcare, we're talking about Medicaid, so we have a lot of contracts with Medicaid plan, the FQHC, if we're working with the federally qualified health center. And sometimes it's a granted program like we have in New Mexico with Navajo Nation or in Alaska with Juneau Medical Center. So all of those.
Thank you. And Perry?
Yeah, Siggy, thank you for walking through that. Just was curious, maybe going a little bit off of Courtney's question, just was curious on your team and just the makeup, particularly of the clinical side, just kind of the number of folks you have on the team today, the range of expertise, just any other details there would be great.
Absolutely. So we have doulas, nurse practitioners, lactation consultants, midwives, mental health providers, social workers, diabetic educators, nutritionists, and then community healthcare workers. Behind me is our Africa program. We also work in Africa with community healthcare workers. So the entire gamut, but we do not provide medical services. Our patients get their medical services at the medical home. And then BabyLiveAdvice is the extension and the augmentation of that team. So really not breaking the silos or creating further silos in care. We really are focusing on the medical home, something that is called centering pregnancy, which is a concept that's been around in the United States for over 45 years.
Great, thank you.
Thank you.
Thank you so much. And we are now on to our seed stage companies. Thank you,
Thank you,
Siggy.
guys.
Really appreciate it. So we have two companies presenting in our series seed. And first up is Mika, if you'll please tell us about your company.
Perfect. Hi, everyone. And I don't know which camera we're on. Hi, everyone. So excited to be here and present to you all today. I'm Mika, the co-founder and CEO of Malama Health. Malama means to nurture or take care of. And we are on a mission to improve pregnancy-related outcomes at a moment where nearly 7 million women in this country have low or no access to obstetrics care, and where too often the pregnancy journey is synonymous with fear and uncertainty, just like Siggy was also detailing. Next. Thank you. I am also a mom of two. I have a 2-year-old and a 2-month-old. And in my first pregnancy, I was diagnosed with gestational diabetes. At the time, by day, I was director of clinical product innovation at United Healthcare, where I supported an MBO of $200 million in cost savings. And by night, I was scouring research articles, anxious, trying to figure out how I might improve the likelihood of having a healthy baby. In the 2 years since, fast forward, I've returned to graduate school at Stanford, where I met my amazing co-founders, including Danny, an entrepreneur and equity designer, Orlando, who's previously a senior software engineer at Airbnb, and Shamali, who is a PhD, finishing her PhD at Stanford Medicine in health equity. Next. And we are supported by an amazing team of clinical advisors from Stanford Healthcare, the NHS, as well as previous executives at Gluco, Baby Center, and large health plans. Next. And together, we have launched the first remote monitoring platform specifically designed to meet the unique needs of patients diagnosed with the most common metabolic disorder in pregnancy. This is just where we're getting started. So for all of you thinking, oh no, another point solution, just wait. And through partnerships and provider collaborations, we are building the tech layer to enable personalized, culturally competent care from preconception through postpartum. Our app today is available in English and Spanish with Mandarin and Vietnamese and other languages queued, and designed as a plug-and-play solution with quick links for Epic integration and a provider dashboard that is up and running within 72 hours. Next. Next. So far, we have 8 pilots and 2 clinical studies with the UC Consortia, UCSF, UCLA, UCSD, and Tufts Medicine, as well as pilots with Santa Clara Valley Medical and Harbor UCLA, which are both over 90% Medicaid populations. Next. Since launch in fall of last year, we have over 250 patients who have been attracted organically. We have a retention rate for provider referred patients of over 90%, and perhaps most significantly, and excitingly, we are seeing a 15% improvement for patients who log with Malama versus the existing standard of care. We expect preliminary results from our IRB studies in Q3 and will subsequently roll out to payers and employers as part of a bundled maternity solution. Next. We have an amazing roster of supporters. We're backed by Y Combinator, Alpine Investors, Coyote Ventures, Samsung Next, and more. We do have a small amount left in our current seed round, and we are ready to pilot with plans. Our ask today is introductions to integrated delivery networks. We're especially looking for connections to Kaiser, and also regional health plans with high rates of diabetes in their populations. Thank you so much, and we are ready for any questions.
Thank you. I believe, Perry, you have the first question.
Yeah, thank you, Mika, for walking through this. Really, really exciting. Like you mentioned, a very big unmet need there with gestational diabetes. Just was curious, I know you touched on it a little bit, but it seems like this platform could have broad applicability beyond just the diabetes front. Just was curious if any initial thoughts on kind of, when or where you might try to go next.
Yeah, thanks, Perry, for the question. So as mentioned, we're starting in gestational diabetes. The modules are applicable for pre-gestational diabetes as well. We're very focused on culturally competent care and offering our services in multiple languages, just given the populations that we work with, as well as the fact that minorities disproportionately represent, are affected by diabetes, as well as hypertension, some of the other comorbidities. What's unique about what we're offering is personalized real-time insights, as well as the culturally competent educational modules that providers can build in. The reason that we started here is it's the foot in the door, hair on fire problem for providers. So our MFMs at Stanford that we work with spend about half their time literally just, what did you eat for breakfast? What did you eat for lunch? We're starting there and building that trust with providers through our IRB studies, through our pilots, and from there expanding to other conditions to extend the latitude of care for our OB and MFMs.
Thank you. Another question from our panel.
I have just a question on competition in this space. There are a lot of companies out there. I think your focus on gestational diabetes is one way of differentiating, but I wonder if you could talk a little bit about where you sit in the landscape of maternal health platforms.
Sure, thank you. So, thank you, Elizabeth. So we're starting again in gestational diabetes. We're flying kind of under the radar of the Omada, Averta, Vitas of the world who focus on type 1, type 2. Typically, the space is overlooked and underserved, given that several of the kind of more chronic care management companies either exclude pregnancy completely as a condition, so like a Noom, 9am Health, or they're based upon weight loss modules or carb cutting that isn't applicable in pregnancy. So that's kind of the diabetes space. The maternal care platforms, there are several like Pomelo Care, Maven, who are focused on provider networks, and we're looking to serve as the tech layer for a lot of these provider networks to really enable and help them take on risk. So depending on how they're positioning and whether they're working for with fee for service or more value-based care organizations, serve as the tech layer to help improve efficiencies, help collect that data, help with risk stratification, and so on.
Thank you. And judges, we have time for one more question.
I'm happy to jump back in again, Mika. Just was really impressed by the kind of engagement and retention metrics that you mentioned. And I think it's always something that's a little bit nerve-wracking, something where there's a lot of kind of need for the patient to be kind of self-reporting a lot of these different items on a regular basis. Just was curious kind of your view on like why you think you're seeing such great engagement and retention thus far.
That has been a big focus since we graduated Y Combinator in the fall, has just solely been on get that retention and engagement up. That's our weekly, our North Star. But we've run multiple experiments to really try to improve that. And have a lot of data on and have different hypotheses why it's working now. But one quick thing is just the real-time feedback, real-time insights. So typically when I had gestational diabetes as well, you write down on a pen and paper, there's no feedback, you don't know where this data is going. You may see your provider in 2 weeks, in 3 weeks. You forget your logs. You're in this, you're feeling isolated and kind of in a black hole. And so we are actually taking that data and showing that it's affecting their care plan and treatment and affecting baby's health, and giving them insights into patterns and helping identify triggers and so on. So all of that kind of real-time feedback, as well as bigger picture view, keeps the patients coming back, as well as provider trust, of course. So
wonderful. Thank you so much. We are now going to hear from our last seed company, Cipra. We welcome you to the stage.
Thanks so much. Really excited to be here. Next. And jump right into the problem. 41 million women in the United States suffer from a mental health disorder. Out of that, over half of the women go completely untreated, 23 million. And on the ones that do get treatment for mental health issues, there's on average a decade in between symptom onset and getting into treatment. These huge delays in care or lack of care have huge social implications, economic implications, as well as epigenetic changes for women of childbearing age that then increase the incidence of mental health disorders in their children and then their children to come. The American Psychiatric Association, as well as the American Pediatrics Association, declared a mental health emergency in our country last year, and this is an incredibly large market size. 40 billion per year is calculated by $1,200 of treatment times 33 million women that fall into the mild to moderate category that could be benefited by a digital health solution. Next. So we're LunaJoy. We're a digital health, mental health clinic specialized for women across the lifespan, everything from adolescence, pregnancy, postpartum, infertility, miscarriage, all the way through perimenopause and aging. Our youngest patient is 16 and our oldest is 88. Next. Just a little bit of background on us as co-founders. I'm Cipra Alada. I'm a perinatal psychiatrist by training. Worked in the health system, both in private practice as well as in the hospital system for 10 years prior to starting LunaJoy. I was chief resident at Emory and helped develop telehealth clinics that would take patients that were overutilizing acute care services and funnel them into regular care before transferring them back to primary care. Most importantly, though, I'm the mom of 4. Had a set of high-risk twins during residency during my chief year. That was also the year that I was getting my perinatal specialization and taking care of women in the Emory Perinatal Mental Health Clinic. So I was seeing this really on both ends as a patient going through the system, realizing that despite seeing every specialist under the sun with my high-risk pregnancy, that there was absolutely no mental health care safety net that was built, and then seeing these women in the clinic and treating them, realizing that most women were waiting 6 months to a year to get into specialized care. Really seeing, aside from access issues, the conduits between OBGYN, maternal health care, and mental health care were completely fractured, just non-existent. My co-founder is Shema Rathi. She's a child and adolescent psychiatrist, also happens to be my sister-in-law, is the mom of 2, and was instrumental in building our women's mental health training series, which all of our providers take on our platform to have this unique specialization that otherwise women really suffer in getting access to. We are a Y Combinator-backed company and participated in their winter 2022 cohort. Next. 1 year since launch, we've seen incredible growth, on average 20% monthly growth in our number of appointments month on month. Our most utilized appointment types are medication management, psychotherapy, either groups or individual, coaching, groups or individual, and genetic testing. So our services span from coaching, peer support, to clinical services, including therapy, as well as medication and medical management. We've had over $500,000 in total revenue and hit 90,000 in December of 2022. We're projected to achieve 1.8 million in 2023. So far, we've been largely B2C, and now we're shifting into adding B2B, integrating directly into OB offices, into labor and delivery units, and NICUs. We have 22 providers working and 8 internal staff. Currently, we are the only full stack mental health solution focused on maternal and women's mental health across the lifespan, offering medical and peer support services all under one roof. Next. Being primary clinicians and working in the system, we have a unique patient acquisition strategy rather than focusing on digital marketing, which is what many of our mental health peers do. We've embedded assessment tools directly within health systems and OB offices to be able to pick up positive screens earlier and also to be able to encourage our practitioners to do those screens earlier. Those results come directly to our platform, and we outreach patients within 3 hours of positive screen, offering them not only education and resources, but an appointment on our platform. And so with this, we're able to acquire users at minimal CAC, increase early detection, de-risk handoffs between mental health and maternal health, as well as really shift the paradigm from crisis-based care, which is how most of maternal mental health care is done right now, to proactive and preventative. Next. We've seen insurance as the way to scale. Instead of starting with subscription-based models or fee-for-service directly to patients, we incorporated on April 1st, 2021, and we sent out for insurance contracts the very next day. We have since won 3 national contracts with Humana, Cigna, and Magellan, as well as regional contracts with multiple commercial and federal insurances that are coming in state by state. We are currently delivering services in Florida, Georgia, North Carolina, Illinois, California, and Alaska, and coming soon in the next month to Texas and New Jersey. Next. So to summarize, we've taken a multifaceted approach. Being clinicians, we understand primary care doctors are burned out. Over 100,000 primary care doctors and OB left the workforce in the last year. OBs are left holding the bag with the maternal mental health crisis that we have. We don't currently have mental health specialists that are trained in reproductive psychiatry, so we offer behavioral health integration. We see people through our clinic. We are raising the provider workforce, offering specialized training for every provider on our platform. And we also understand that mental health care is inaccessible, especially for women. So we're offering specialized care as well as in-network appointments. Next. I won't go through everyone on the slide, but we have an incredible diverse team that has come together very quickly to help us not only expand states, but get into more offices and access and treat over 1,000 patients in this last year. Next. So our ask is for introduction to OBGYN groups and health systems, as well as introductions to any payers that are interested in maternal mental health and potentially setting up digital high-risk clinics and interested in value-based or fee-for-value care. Thank you, Zipralada, and I appreciate your time. Happy to take any questions.
Thank you. And Elizabeth, I believe you have the first question.
Thanks, Cipra. As you point out, that we have this huge public health crisis around mental health, and some of that stems from lack of access. And so I'm curious, as you build your provider base, whether there are any challenges as you think about scaling. Are there enough behavioral health specialists to be able to serve what I'm sure will be a growing number of women who want to access your services?
Yep, I love that you asked that question. And so it's kind of my answer is two-pronged. First, part of scaling and bringing on behavioral health practitioners, whether that's psychiatrists, physicians, PAs, NPs, therapists, for us at this early stage has been actually relatively easy to do. What we understand is that a lot of the practitioners really want this specialization. Right now, specialization is expensive and is not very widely offered. And so they're able to come onto our platform. They're able to have that collaborative environment. They do the training, and then they have support to be able to offer that care. So right now there's kind of a value add for the providers that we're bringing on. And then from the patient's perspective, in terms of the population that we're trying to treat, there's never going to be enough perinatal psychiatrists or behavioral health providers for the population that we're trying to treat. So we're doing two things for that. One is that in getting women earlier in pregnancy, rather than waiting for 6 weeks postpartum to screen, we can offer lower acuity services. So a woman that we're screening at 20 weeks pregnant can fall into a group coaching or even a group therapy. So it's one provider that is taking care of 8 to 10 patients at a time, as opposed to they're 6 weeks postpartum, they're really depressed, maybe they're having a lot of dysfunction, and they really need to see a psychiatrist and a medication prescriber, which happens one-to-one and is really difficult to access those appointments. So using a combination of group care and individual care, as well as getting patients started preventatively, which is the paradigm that we have in primary care, kind of bringing that to behavioral health care is how we've chosen to address that.
Okay, we have time for one very short question and short answer. If I could get another question from our judges.
I have one. Oh, no, go ahead, Katie. You haven't asked much yet. Go for it.
I just wanted to hear a little bit more, real quick point of service for the provider, like what exactly that looks like at point of service. And I love so much of what you're doing, and delay in time to care is a huge health equity issue, and love what you're doing. But just, yeah, thankful you're looking at providers in the mix of things and want to just understand that piece a little more.
Yep. So again, being a physician, no one wants a positive screening test that they're not going to be able to action upon. And that is the biggest pain point for providers. OBs don't want to do screenings early because they have a positive screen, they have nowhere to send the patient, and they don't have the resources to be able to often handle the full scope of that mental health disorder. So we basically are getting into the offices and offering multiple levels of integration, but often doing the screens for them via our technology or our integration. We're getting the screens directly. We communicate with them by the end of every business day. They see all their patients that screen positive, what those scores were, where they are in the pregnancy, as well as the actioned upon items. So, we followed up with patient. They're going to see us Tuesday at 4 p.m. The OB looks at that and is like, great, sounds good. I know where my patient is. I know what they're going to do to address the mental health issue. It's going into my EMR now. And then we send our notes back and collaborate with them very closely. So we basically wrap around the OB to provide mental health care to their patients.